I'm Harriette Spall, cardiologist and clinical trialist from McMaster University in Canada, and I'm so delighted to have Dr. Tauben Averbuch here with us. He's a resident in cardiology training at the University of Calgary. And by way of disclosure, we're on the same research team. Tauben, you're here to discuss a pooled analysis of the PACT-HF stepped wedge cluster randomized trial at HFA 2024, and you just presented your results on the late-breaking clinical trial stage. Tell us the rationale for your study and give us a bit of background.
Thank you so much, and thank you for having me here to discuss our trial. So the PACT-HF trial, or the Patient-Centered Care Transitions in Heart Failure, tested a transitional care model against usual care among patients who are hospitalized for heart failure and discharged alive. This consisted of nursing-led patient education, early follow-up with a family physician, patient-centered discharge summary, and for eligible high-risk patients, referral to heart function clinic and home nursing support. The trial was ultimately neutral at 3 months and at 3 years. Now, we wanted to explore outcomes over a longer period at 5 years. In particular, we wanted to see if there were differences in outcomes based on sex, recognizing that there's quite a bit of controversy in the literature, both in the short and long term following hospitalization, about sex differences in clinical outcomes. We also wanted to look at differences in resource utilization, recognizing that there may be disparities in care between male and female patients with regards to referral to specialists as well as receipt of invasive care. So with that in mind, we carried out a pooled sex disaggregated analysis at 5 years among all patients that were enrolled in the PACT-HF trial.
Sure, and you looked at clinical events such as death, all-cause readmission, heart failure readmission, and you also looked at healthcare encounters and direct healthcare costs. Tell us about the background or the baseline clinical characteristics of the males and the females in your cohort and the sample size.
Of course. So our study included approximately 4,400 patients that were fairly evenly split between male and female patients. Our patients were fairly typical of our usual practice, reflective of the pragmatic enrollment criteria of the PACT-HF trial, with male patients being on average about 73 years of age. Female patients were older, at a mean of 78 years. There was also a greater proportion of preserved ejection fraction among the female patients, with a mean ejection fraction of 49 compared to the male patients' 42%. Now, comorbidities were fairly similar with some differences. There was a greater burden of hypertension among female patients and a greater burden of cognitive impairments and dementia, whereas male patients had more chronic kidney disease and prior myocardial infarction, as we'd expect, knowing a greater burden of ischemic heart disease in male patients. At the index hospitalization, we did see that female patients were also admitted for about a day longer than their male counterparts.
Okay, so some differences in baseline characteristics. Tell us about your results. What did you find in clinical event rates, and did you see any sex differences in those?
Of course. So the biggest finding was that the event rates were extremely high, and I think higher than many practicing cardiologists would realize. At 5 years, about 65% of both male and female patients had died, with no significant sex difference. And about 55% of both male and female patients passed away in hospital. We found that all-cause readmission occurred in about 85% of both male and female patients, with a mean of about 3 readmissions each over the follow-up period. And again, we're finding that the vast majority of patients in our study had at least one clinical event, but no significant sex differences were observed.
Right, so not only a high proportion of patients required readmission, but multiple readmissions were common, and there were no sex differences in those clinical endpoints. What about healthcare utilization, healthcare costs?
So similar to clinical events, the costs were extremely high over the 5-year follow-up. We found that on average, patients incurred about 80,000 Canadian dollars a year at both 1 and 5 years following hospitalization, with no significant sex difference. All-cause readmission did make up the bulk of the cost of close to closer to 50% of total costs for both male and female patients, with a mean of about $40,000 a year for both male and female.
I was just going to say, importantly, those readmission costs didn't incorporate the physician costs, which come from a different pool of data. And those physician costs, if incorporated, would increase that proportion of costs that were due to readmissions, wouldn't they?
Absolutely.
Yeah. And so tell us about the healthcare encounters that people had, and were there any sex differences in those? So overall, there were no differences in costs, but what about the type of cost expenses?
So aside from readmission, there actually were differences in the breakdown of costs between male and female patients. We did see that male patients incurred greater costs from heart failure clinic visits and specialist clinic visits, whereas female patients incurred greater costs relating to home care as well as long-term care, and that was reflective of the greater number of clinic visits among male patients relative to female patients, and a greater number of days spent in long-term care. So clearly, despite a very similar risk profile with a very high risk of events in both male and female patients, male patients were still receiving a greater number of visits with specialists than the female patients.
Right, so even though there was a difference in baseline comorbidities with more ischemic disease in men versus women, slightly greater CKD in men versus women, greater cognitive impairment in women than in men, the risk of clinical events was the same in both sexes, and yet women received less specialist care, less heart failure, disease management care, and also less invasive care. And were you surprised to find that more than 50% of patients died in the hospital when we have so many different ways to organize ambulatory care? What are your thoughts on that finding?
Absolutely. I think it's quite shocking to see that more than half of patients are dying in hospital. I think if we surveyed our heart failure patients, they would say they much prefer to die in the comfort of their own home. Similarly, we recognize that costs are very high for an in-hospital death, and resource utilization is very high at the end of life. And similarly, I think if patients had the choice, they would not be looking for that level of intensity at the end of life. And this does speak to the fact that we need to do a better job of enrolling our patients in palliative care programs earlier in the progression of disease, and as well recognizing when our patients are getting towards the end of life. As we mentioned earlier, with 65% of patients being dead within 5 years, that's not something that we think about when the patient's discharged, but it's something that should give us pause and start future planning for our patients.
And also guide discussions with patients about the importance of medical therapy and the critical, prognosis that lies ahead that we need to help improve. Thank you so much for joining me today and for your stellar presentation at the late-breaking stage this morning.
Thank you so much, Dr. Van Spall, and to Radcliffe Cardiology for having us.